She's got a growth mindset that's extraordinarily clear. She has continued to move herself and her craft forward. And I want her to introduce herself more and talk about how she came to know kinesiotherapy and be involved. But um, I'm going to tag on to that and ask her to talk about something really unique that she did when she worked in the VA. So, Karen, thank you.
Well, thank you. So, let me stop sharing this and share the other thing, the other PowerPoint, then we'll get started with that first. Um, so, my name's Karen Perell Gerson, and I started working at the VA in in the late 1980s when I was a graduate student. And I was I was a kinesiology major at the time, and my boss, who was a physical medicine and rehab physician, wanted me to become a KT. She thought that that would be an excellent way for me to marry the graduate work that I was doing in biomechanics with the clinical aspects. And so I did so, and then finished up and got my PhD in biomechanics. And I ran for several years a fall prevention screening clinic and gait laboratory at the Los Angeles VA. And we set up these fall prevention screening clinics. I partnered with the Tampa VA, who had already been starting to go down that route. And between the two groups, we set up, I believe it was 13 programs in the VAs that were in Florida and the VAs that were in Southern California and Nevada. And they were staffed by a pharmacist, a physician, and a therapist. And some of them had KTs as the therapist, some had OTs, some had PTs, but there was definitely a therapy component. And we ran that for 2 or 3 years under a grant, and then it continued on for some years at some of the different locations. And so I don't know. I've left the VA. I left in 2003, so I haven't been as involved, but we did show some very nice data that I'll talk about briefly when we get to the medication review section as well. So those of you who might be interested in setting up a program for fall prevention, particularly in the VAs, there's a nice, what's the word I'm looking for? Sort of starting place through CDC. They have a program called their Steady program, and I dropped into the chat not this PowerPoint, but a different one that, or it wasn't a PowerPoint, but their program on fall prevention. And so you can see they have what they call a 12-step program of how to get fall prevention screening programs into some sort of hospital setting or medical center setting. And of course, you need a champion is the first part of that, and understanding the literature. And then one of the most important things is leadership support and getting the hospital administrators to really back this idea. It is labor intensive, but as the data show, and I haven't presented a lot of that data, if that's something that you want me to talk about at another time, there's really good cost data out there about cost savings in terms of, while it is labor intensive, it definitely does over the long haul save money. And maybe even more importantly than money is help our older adults feel safe and be able to live more independent lives. And so here you can see how this is the second part of it. And just as a note, this number 8 in terms of the health records. So this was back in the late 1990s. So over 25 years ago, when the VA was pioneering electronic records. And we would put if our Falls Clinic records into this electronic system, and other clinicians would actually read it and make changes. So we didn't take over care. We were a consult clinic, but they read the results of our clinic notes and actually acted upon them. And we were very surprised, to be honest, because electronic records were really in their infancy. But we were also tremendously excited that that was in a large scale hospital setting like the Los Angeles VA, that that was happening. So just a note of that, but we'll get back to the clinical aspects of fall prevention now, unless anybody has any questions that you want me to answer first. Anything in the chat that I should? No? Okay, great. Can everybody see my presentation?
We have one question. Is it similar to the STRIDE program?
I'm not 100% aware of the STRIDE program. That's not, we didn't have a specific name for it. We just called it our fall prevention screening clinic. I would imagine that there are many iterations and versions that are popped up all over the place. When I was doing my literature search for this uh, presentation, there are so many different programs that people are doing across the country, and even internationally. The one I'm going to present some information from is actually originated from New Zealand. And they have a wonderful site that really walks you through a program. I think that the most important thing with any fall prevention screening program, and this is sort of putting the cart before the horse, but my last slide is, it really is a team approach. It requires comprehensive care. Our Practice Act is predominantly exercise related, but we can only do so much if the medications are out of whack, or there are medications that are causing balance problems, or a patient has vision problems, or their home environment is unsafe. Any of those combinations are going to put an older adult at risk for falling. And so what's really most important is that coordinated care, having all the players involved. And so whether what we call it, everybody has different names, but that coordinated care is really so important. So I'll go ahead and get started now. At least I hope I will. There we go. So I'm going to very briefly talk about risk factors. I've focused on community dwelling olders for individuals who would be in a hospital setting or in an assisted living or a nursing home. That the many of the intrinsic factors would be even heightened. We'll talk about specific exercises, some home strategies, and then I'm just going to briefly talk on medical issues, not necessarily for us as KTs to address, but to advise our patients to talk to their providers, or if we are setting up a comprehensive type of care, to make sure that those aspects are included. So just some data. You've probably all seen this before. there is, and I apologize, I don't know why it's not showing up very well now that I've put it on screen. So, whoops, it's not what I wanted to do. I'm sorry. All right. Well, for some reason it messed it up. So I am very sorry about that. Um, but this data show some of the issues related to problems, the numbers involved. I don't think I'm probably telling anybody anything that they haven't seen before in terms of the dire consequences that result from older adults falling. Um, you can see more of that information in a program that the CDC has put out. They have some really nice brochures that can help in terms of for practitioners as well as for patients. Their program is called Stopping Elderly Accidents, Deaths, and Injuries, or STEADY. And what their role or their guidance is to screen patients who are at risk, to assess those modifiable risk factors, and then intervene with effective strategies. And I want to go back to this screening for a moment. The um, falls prevention screening clinic that we implemented when I was working at the VA, one of the things that we did for inpatients facilities was we talked about the idea of universal precautions, because there are lots of screening tools, particularly for individuals who are in hospitals, assisted living, or nursing homes. But when 90% of your patients screen for being at falls risk, you really don't need the screening tool. What you need is the idea of ensuring proper care across all patients. So just like we all wash our hands and use universal precautions, not wanting to necessarily identify any one particular kind of patient who might be more at risk for infectious diseases, the individuals at the Tampa VA sort of coined the idea of universal precautions for fall risk patients, particularly in these areas that we know that more than likely the patient is at fall risk. But screening those individuals in a more community setting where you have a wider diversity is certainly very important so that you can provide the appropriate interventions for the appropriate people, especially when staffing is low and interventions are costly. So here are some of the resources that are shown here, and I've put the website for you to utilize. Here are ones for patients and caregivers, some of the issues that individuals should be aware of. And then here are some of the common risk factors. I've highlighted in green and bolded those that are within what we as KTs can really have an impact. Muscle weakness, gait and balance, fear of falling, and improper use of assisted devices. If I ask by a show of a thumbs up or a hand, how many people have had a patient come in and they said, oh, I borrowed my neighbor's cane. They weren't using it any longer. Or I got it at the store and have had no training for use of assisted devices. Anybody have that problem? All right, so key components to a fall prevention program are the exercise interventions, which we as KTs are very well suited to help with. Home modifications. This often is under the prelude of KT, or excuse me, of OTs, but in many of the studies, they've shown that really individuals only need between a half a day and 2 days of training to really go in to understand and identify home modifications. So it is something that potentially KTs could do. Education programs to help patients recognize risk factors, understand the issues related to home modifications, and certainly the idea of maintaining their exercise even when they've been discharged from an activity. Medication review. I can't stress enough, while this is not the preview of KTs, educating our patients on having that conversation with their physicians and pharmacists regarding the medications that do have an effect on gait and balance. And then lastly, behavioral changes. So this is where we can have an impact, helping patients to set goals and to maintain changes in their exercise routine, as well as some other aspects to maintaining proper diet and getting medical checkups. So there are lots and lots of different types of fall prevention programs. I've given you some of the data here and some of the references to these. So this Otogo exercise program that I'm going to present from showed a reduction in falls of 35 to 40% for frail older adults. We have other programs that have shown improved confidence and decreased fear of falling. Others that have shown fewer falls and fall-related injuries. And in terms of trying to get individuals on board who make financial decisions, there have been studies that show positive returns on investment and cost savings. And so as we are entering an ever changing landscape of having to cut costs, being able to show how fall prevention screening clinics actually do reduce healthcare costs is an important thing. So the first thing is to screen an individual. There are several different types of screening tools. The first is something where you can have people fill out a yes/no kind of questionnaire to determine whether or not they are at risk for falls. To begin with, we shouldn't assume that every older adult is at risk for falls, even if that seems to be the people that we see and treat. But there are a whole host of older adults who are living independently and doing very well at it. And so we want to acknowledge that, but we also want to find those individuals who may be starting to have some issues, particularly in the issues of balance and gait, or the medications making them dizzy or unbalanced. Any questions or concerns so far? So what I'd like to talk about now is strength and balance exercises. We would start with a warm up. We would then have some standing balance exercises, strength exercises, balance and coordination, cool down and stretching, and also incorporating exercise into an individual's daily routine. So I'm going to give you some examples of these. It's not an exhaustive list. It's not designed to give you every single exercise that you could prescribe, but to give you some ideas of, in terms of muscle strengthening, the major exercise, muscle groups to focus on, and in terms of coordinations, some ways to challenge patients to have improved balance. So, this Otogo exercise program that I'm going to present today focuses on the idea of assessment activity, intensity, and then we're going to go on to the next slide in a moment. But for each one of these areas, looking at strengthening, balance retraining, and incorporating walking into somebody's daily routine. And again, this was designed for frail older adults. So if you are working with individuals that may be community dwelling, they may already be doing much of the walking unless they are more homebound, in which case we would certainly want to increase the amount of walking that they're doing. And so, what they're trying to do is have individuals participate in 5 leg muscle strengthening exercises and 12 balance training exercises. And they have different levels of difficulty. So, for a patient who may not be able to balance well, you would want them to start with chair exercises and work up to then working independently if they could. Otherwise, maintaining, either holding on to a therapist, holding on to a chair or a wall, depending on the appropriate level of difficulty for that individual. About 8 to 10 repetitions for strengthening, and you want a patient to be able to perform the balance exercises at the level that they can unsupervised. Obviously, you're not going to just leave them unsupervised, but you want to know that you don't move on to another difficulty level until they can do it unsupervised, particularly so that they can maintain the exercise over time and after a program is over. That's one of the biggest problems with exercise programs, is that once a patient is discharged, are they able to do a home program on their own unsupervised? And now, with the advent of telemedicine, there may be ways of doing that in a much more efficient way of having home programs supervised once a month or once a week, depending on the level of need. I have a friend of mine who's a physical therapist in London, and she, during COVID, did all of her patients through Zoom, um, and did exercises and was able to continue with her programs and her prescriptions through Zoom. So we do live in a really nice time in terms of maintaining that contact following discharge. Um, we also have progression and then length of the exercise sessions. So the strengthening and balance combined should be about 30 minutes. Walking should total 30 minutes or more if somebody can, but if not, breaking it up into 10-minute bouts is certainly a wonderful way to get cardiovascular exercise as well as incorporating strength and balance into daily routine. And if you ever wondered why we use that 10 minutes, it has to do with that we get about 90%, excuse me, 80% of the aerobic benefit from doing 10 minutes that we do at 30 minutes. So for a patient who's struggling, who can't walk for 30 minutes at a time, whether it be because of muscle strength or balance problems or cardiovascular, by having them do 10-minute bouts, we actually are accomplishing a tremendous amount for them. Excuse me. And then the Otogo program lasted a year. Whether or not in a clinical setup we would have that opportunity is unlikely. But again, if it could be designed with some home supervision, through telemedicine, that would be a fantastic way to maintain contact long term. And that really has a benefit of helping with behavior change as well. So you may have seen some of these assessment tools already. The 30-second chair stand. So you're asking a person to get up out of a chair. I just realized this is a very bad picture because we don't want chairs to have wheels. And I apologize, I didn't notice that before. So please do not do this with chairs with wheels. Um, but you also want chairs that do not have armrests. The idea is to use only the leg muscles because that's what you're assessing with this particular physical test. And so you don't want an individual to push up using their arms because their legs are too weak. So if they can't get out of a chair without using their arms, then we would say that they scored a 0, and that you know that you need to work on leg strengthening exercises for them. There's some nice normative data for a very large range of individuals as well, both for men and women. Then we look at the balance test. This is a standing test that gets progressively more difficult by reducing the base of support until they can no longer maintain that for 10 seconds. And again, anybody who can't at least do the tandem, one foot in front of the other, for 10 seconds is at risk for falling. And then the timed get up and go, timed up and go. There's another one that's called get up and go as well. This one looks at mobility, and you want them to be able to not only walk in a straight line, but also go around the cone and come back. And that's a very important part of this test, because that pivoting or turning is very indicative of the potential for falls. And so an individual who takes a longer amount of time to make that turn, their overall score is going to then be longer. And so anybody who takes 12 seconds or longer is at high risk for falling. And again, it's a large part of that is that changing direction.
I have seen probably 5.
Oh, so are there any questions or comments in the chat? Kathy, I haven't been monitoring the chat. Is there anything I should see? Nope. Okay.
There is one,
Oh,
Karen, any information regarding the difference between the 30-second chair stand versus 5 times sit to stand?
so it's different. People will argue for different ways. One is how long does it take for somebody to do 5 chair raises? Some people can't do 5. So that's why other researchers will argue for the 30-second chair stand. If you have a more community-based population, then the 5 chair stand would probably be fine. And you wouldn't see necessarily a floor effect or a ceiling effect. But again, if you have a frail population, which is what the Otogo exercise program utilized, the 30-second is a better option because then you can see if they can even do 1 chair raise. So that's a great question. Thank you very much, whoever asked that question. I appreciate it, to show the difference. And there are, like I said, there are a multitude of different tests out there, different assessments. And really what we need to think about is what's the population that we're assessing? And will the test provide us with the validity to see who is at risk and who is not at risk for falling? Thank you. Okay. And then we look at warm-up exercises, getting individuals just getting some movement. These don't necessarily need to be large cardiovascular kinds of activities, but they can just get some range of motion. You can see that at the neck, at the trunk, these could be done via sitting, or they could be done standing, depending on the level of your patient. Then we move into strengthening exercises. And again, what I've tried to present here is that you can do these in both sitting and standing. You could have somebody holding on to the chair or not holding on to the chair, depending on the level of difficulty that you are trying to achieve. Okay. In the Otaga program, they also will have the individual have weights on their ankles. So a 5-pound ankle weight, as they can do these exercises safely, then to add weight to it as well to add difficulty. Here are toe raises. This picture for the toe raises is not very good, but you're actually standing and trying to get the toes up as opposed to doing a heel raise or calf raise here, where you're lifting up your whole body weight on using the plantar flexor muscles. So you can tell that this is a much more difficult activity, this calf raise, from the toe raise, where you're really trying to just get some dorsiflexion, range of motion, and strength. But it's very important, this dorsiflexor activity, because as I'll show you with some of the balance techniques, you're going to want people to walk on their heels and their toes to reduce basis support and be more challenging from a balance standpoint. And then we have knee bends, and we have that sit to stand. Okay, this is a much better, I should have used this picture. This is a much better chair for sit to stand. Has no armrests, but it is a stable chair. When we move into balance exercises, We have the heel to toe stand. So this is that tandem stand that was assessed previously. We have a one leg stand with assistance and eventually being able to do it without assistance. And the importance of one-legged stance can't be estimated or overestimated, underestimated. It's really important when we walk. If we have a natural gait, we have to have a swing phase. And so we have to be on one leg with all of our body weight on that one leg. If we can't stand on one leg, it shortens the stride that we take, making it so that we shuffle. And when we shuffle, like with a Parkinson's patient, we're going to increase our risk of falling because we're going to hit something, or we're not going to be able to walk over something. And so this being able to stand on one leg from a balance perspective as well as from a muscle strength perspective is very important for fall prevention. And then sideway walking is improving the abductor muscles so that they can keep us upright. We use our abductor muscles quite a bit for upright stance, and we want to ensure that they are strong. And this is a nice way to do it. I even saw when I was looking at some of this that to add a level of difficulty, you could put a box and the person not only had to sidestep, but they had to step over the box. And that would add a level of difficulty to this activity. Then there is the idea of once you can master the standing and just moving side to side, then there are challenging approaches to walking. Backward walking, heel to toe walking. In heel to toe walking, what you've done is really reduced that base of support. In backwards walking, you're probably going to see an individual taking a step and having a very large base of support to balance themselves. And then the idea of heel to toe backward walking, where you are doing the opposite of the heel to toe forward walking, and you're trying to get somebody to move their leg behind the heel. Then the idea of walking on heels or walking on toes. Again, that idea of reducing base of support in order to encourage balance. And then a figure 8 walking. So remember we talked about in the up and go test that making that turn. And so a figure 8 walk requires quite a few pivot changes. Before I go on, are there any comments or questions? Anything you'd like me to discuss in further detail in relationship to exercises? Now what I'd like to do is spend a little bit of time on home safety strategies that you can discuss with your patients. The idea of grab bars, shower seats. This is something that you may already work with your patients on. Handheld shower heads or adjustable shower heads, raised toilet seats with armrests. And then something that's much more costly and may or may not be feasible for all patients, but to convert bathtubs to a curbless shower. Lighting improvements. So one of the things that's an issue for older adults is vision, particularly that being able to distinguish in low light situations. And so ensuring that bulbs are um, not burnt out and that they are well lit areas. Particularly night lights or some sort of motion activated lights for nighttime issues. We know that often our older adults go to the restroom more often as well. And having a pathway that's lit or becomes lit is important. And then the idea of stairs and making sure that the stairs have good lighting and that the whatever is on the stairs does not create optical illusions for older adults as well. And then continuing on with the idea of flooring and stairs, throw rugs, hallway rugs, any of those kind of things pose a huge risk for older adults unless they really are they have a non-slip backing and they are secure to the floor, so they're not going to move around. Floors clear of clutter and obstacles. That might require handrails on both sides of the stairway. So that's another option. And then the idea of non-slip treads for steps that might be wooden as opposed to carpet. One of the things that I really do want to talk a moment about is the idea of medical management, medication management. And while that's not under our purview, it really does represent a very important piece of an overall comprehensive care program for fall prevention. If an individual is taking medications for other factors, but those medications interfere with their balance, then we really are going to struggle to maintain a reduced risk of falling. Now, that's not to say that we can always take them off the medications, although if there is a way to reduce medications or reduce the number of medications, reduce the dosage of medications, that would be wonderful if possible, so that there's less interference with balance. If not, then knowing that a patient is on those medications and really addressing the other aspects of balance that we can address, like muscle strengthening and reaction time. And so that's something to be aware of when your patients take medications. In the fall prevention screening clinic that I alluded to at the beginning, one of our most striking results from our electronic records was that primary care physicians reduced the number of medications. So they went back and they looked at how many medications a patient was taking based on our consult clinic and were able to reduce that number. And so it was a significant finding that we had, and we were very proud of that because it really helped our patients reduce their risk of falling. Additionally, nutrition. So protein, oftentimes as individuals get older, they eat less, and particularly they may lack enough protein. And protein is very important for muscle mass and strength, as well as bone health. It's the organic materials that keep bone resilient. And so as we age and start to have osteoporosis, what we're losing, in addition to overall muscle mass, we're losing the organic material, that collagen that's in the bone, that's giving bone its resiliency. And so not only are we at risk for fall, but we are then at risk for fall with injury, which is an even more problematic aspect to this problem. That didn't make sense, but anyway, more problematic to this situation. Calcium and vitamin D for bone and muscle health. We need both of them. Again, ensuring that individuals have an appropriate level, working with their physicians and a dietitian, their overall nutritional status, and ensuring that they don't have malnutrition. And then lastly, trying to maintain a healthy weight. It actually, underweight individuals are at greater risk for fall with injury because there isn't the padding, and overweight individuals are at higher risk for falls because they're carrying that weight and they may not have the muscle strength to do so. So we ideally trying to work with a patient to get to that ideal weight. And then lastly, in terms of medical issues, vision, educating our patients to get regular eye exams, make the home modifications that might be necessary as vision starts to become problematic. Understanding that eyes will adjust more slowly. So lighting situations, wearing sunglasses, hat. And one of the suggestions that I saw that I thought was interesting is using single lens glasses for walking instead of bifocals or trifocals, because this way an individual may not have to make so many judgments, figuring out what they're looking at, particularly distances. And so I'm not suggesting that we as KTs make this recommendation, but educating our patients to discuss these ideas with their ophthalmologists so that we can work as a team. And then just to finish up, it really is a team approach. Fall prevention programs improve strength and balance, but they're not sufficient. We need the medication review to identify medications that may affect balance, cause dizziness, and having regular medical checkups to assess any other issues like vision and or nutrition, or orthostatic hypotension. So there's a whole range of things that having those regular checkups and having a team approach to a comprehensive care consult clinic really can make a difference. And then I just put some additional references in for you, just so if you want those. And I did drop into the chat to the STEADY program and the TAGO program. Their programs for exercise and balance. So you have those at your ready. So questions, comments, what can I do to help? I'm going to stop sharing now.
Feel free to unmute yourself and ask a question directly, or you can put it in the chat and I'll ask it for you.
I overwhelmed you all?
This is Mark Frazier. I was going to say that a lot of patients of mine have their grandfathers and their grandmothers and their uncles, canes, walkers, and crutches and it's really not. And of course, they're not measured, to fit, and they probably didn't receive the training and practice that they needed to begin with.
Yep.
So that was a huge problem during my practice.
Absolutely. There's some unfortunate good, I mean, I hate to say good data because it's unfortunate that assistive devices actually can contribute to fall risk when not used properly. Thank you for bringing that up. I hope that I have motivated you to maybe think about if you are at a place that could potentially have some sort of consult clinic or comprehensive care, or just start small. It doesn't have to be large scale. You could start with an exercise and balance program and some education. That goes a long way. And behavior change. If you especially that I think is a piece that we probably don't spend enough time on. Is really, it's great to say we should all exercise or we should all do this or all of those things, but how do we incorporate it into an actual behavior change is something that we probably should spend more time with our patients on, because we all know these things are good, but whether we actually do them or not is a whole different story.